I'm going to give one more, and then we're going to take a coffee break, and Joy and Jess will discuss that. So let's talk about CEUS imaging options. And I have to say, it's going to be a little bit different than what you think it is. I'm not going to strictly stay by the rules here. I'm just going to shut the light. Okay, so let's talk about where are we going with bubbles. Well, we've talked about 3D and contrast and potentially strain. Let's talk about therapy. Can we use the bubbles to treat patients? Well, you say we're already saving lives. Well, that's diagnostic. Let's turn the page. This is going to be a little bit different, folks. Can we treat patients with bubbles? So I'm going to highlight just a few. One is Beth McCarville. She's a pediatric radiologist from St. Jude's. I want you to see what she's doing with bubbles. And Tom Porter can speak for himself. And he is opening arteries in patients who have acute heart attacks by using bubbles. And then in Bergen, Norway, they're treating pancreatic cancer with bubbles and chemotherapy. And University of Toronto treating brain cancer with bubbles. So this is very exciting stuff yet to come. So here is a patient scene, a young lady. This is from Beth McCarville at St. Jude's. So on the left is the tumor, and on the right is the tumor. And the response is called stable disease. And I know we have an oncology specialist here too, thank you. So this is called stable disease. So you begin the image, and you follow the image at 1 week with big box imaging, either MR or CT, and say, yes, the tumor is the same size, so that's stable, right? All right, is it? Let's take a look. This is the patient, and this is the tumor with bubbles. That's probably not good. The tumor is filled with contrast. Let's look at 1 week later after anti-angiogenesis therapies. This is 1 week. The microbubbles go through the capillaries. They don't go outside the capillaries like other imaging agents. They stay in the capillaries. So what you have here on the left is a patient with a tumor that is terribly vascular. The reason tumors grow in carotid plaques and all other kinds of plaque, if you're more than 250 to 500 microns away from oxygen, you will grow new blood vessels probably within 48 hours with the VEGF. So new blood vessels will come in. So when a tumor grows so rapidly, the core of it is quite oxygenated or deoxygenated, and it needs new blood vessels. So it sends out a signal called tissue ischemic factor, and you grow VEGF and you get new blood vessels. That's on the left. When you kill the blood vessels with anti-angiogenesis therapy, you kill the tumor. This has long been thought we could do this. Well, this is an example of treatment of a young kid with a tumor. And you can see contrast now adds a new dimension. It is stable from a tumor size point of view, but the metabolic processes within the tumor are dead. It's a very nice example. All right, Tom can talk more about this, but this is a most remarkable thing. So a patient comes in, is having a heart attack, and the heart attack is often caused by a thrombus or a blood clot in the artery of the heart, usually sitting on top of some plaque of some size. So who thought that if you used microbubbles intravenously and put the ultrasound beam over the heart and you pop the bubbles, or let's call it disrupting the bubbles, you could disrupt the thrombus on the plaque and open the artery, right? So this is very big news. Tom has been on this with Wilson Matthias in Brazil. Now there's other people in Holland, up in Canada, are beginning to move into this. So these were the real pioneers. Now, you probably can't see this real well, but I'd like you to look right here. There's an SD elevation MI, and you see the apex here, black. Look at, this is after anywhere between 15 and probably 20 minutes of constant ultrasound and infusions of low-dose bubbles, not for imaging, looking at the heart, and they opened the clot. Now, Tom will speak to this and maybe in a minute, but I just want you to see this is some of their early data. So when a patient then comes to the cath lab, what percent of those arteries and the people who had heart attack were open? Well, baseline about 20%. You take everyone coming down the street, heart attacks, go in the cath lab, about 20% are open arteries. And Tom, about 60%, about 3 times that of normals. So when you open an artery, you get the blood going back and you preserve muscle. So dramatic changes. Now this is therapy. It is right now in the hospital, not in the ambulance. Tom, any comments on where you are with this? Do you have your mic there?
Yeah, well, I'll show you some I'll show you some updated data on this afternoon that we just presented at the ACC, which is even more exciting in the area of reducing infarct size. But yes, the next step would be to try to use the portable ultrasound systems that are available to us to try to get the treatment started when we see the patient in the ambulance or at the point of patient contact. So, and Otto Camp is working on that with a PhD fellow that we're sponsoring in Amsterdam.
So we will be doing that, folks. We will be called to the ER probably, or if you're not in the ambulance, riding along. But what Tom's done, as soon as they hit the ER, you start treating. You don't delay the time for the angiogram. No. This is 15 minutes, maybe 20, 30. You know, there's a delay from hitting the ER. You start the treatment right away. It's changing outcomes. Okay, that's really nice. Now, what about pancreatic cancer? Well, this was a study that was published in 2013, and Linda and I actually had the opportunity to go over there. And I have to say, it was probably the most exciting moment I'd seen in Bubbles in my lifetime. Here's a 60-year-old lady with pancreatic cancer, inoperable. That means it's either wrapped around her aorta or it's metastatic. She was enrolled in this study, along with 11 others. And so this is metastatic pancreatic cancer, and I think you know the outcome. It's rather bad for these patients. So what they did, and I'll put the next slide up. This is the group, by the way, and there's their paper. It was not published in a clinical journal. Nobody knows about this. They took a probe and took a sort of a mechanical device and fixed it to the belly of the patient because they wanted it held there for 61 minutes. Now look at the top bar here. From 0 to 30 minutes, what did they get? Chemotherapy, gemcitabine, a nucleoside. So, okay, and they did diagnostic scanning. No bubbles. After 30 minutes of the chemo, you flush the IV out. And this was important for their IRB because they said, we're not going to mix gemcitabine with the bubbles. We give the chemo, stop, clean the IV, start. And what did they do? Basically 18 minutes of bubbles after that. So at 18 minutes, the nurse was there, and every 3 to 4 minutes, she would give more bubbles. We'd see the pancreas light up, and the machine was turned on, so it wasn't popping the bubbles. The MI was around 0.3, 0.4, quite low, and I'll show you a picture. But this went on for 18 minutes. They did this once a week, 1 time per week. What did it do? It helped get the gemcitabine into the pancreas to kill the tumor. This is what it looks like. So this is that patient's abdomen, and you can see the pancreas right in the center there is very bright white. So when people say, oh, the pancreas has not much blood flow, when there's tumor in there, it has a lot of blood flow. That helps us because the bubbles go to every capillary. You turn the ultrasound on, you open the pores, you get your chemo in. Okay. So what's the end result here? Well, on the upper left, this is the number of chemo cycles. So when they got gemcitabine plus the bubbles, they had many more cycles of chemotherapy. And gemcitabine is fortunately not a terrible lethal chemo. It's not that bad. So patients were tolerating more treatment. Let's look at, did they live longer? Now, mind you, in this graph, 2 of the people were taken out of the study because after the bubbles, their tumor shrunk and they went on to have surgery. They no longer became inoperable. So we are biased against a good result by taking 2 of the good responders out. All right? But look at the lifespan. This is the number of people who lived longer. And down here we're talking months. Look at the bulk in here. 1 person lived for 2 years. Now, this is the tumor size. So generally, the tumor shrunk. Now, this was based earlier on mice studies. So it wasn't just a random clinical trial. Next stop, blood-brain barrier. Yes, that can be opened by using bubbles. And Dr. Heenanen has been at this for many, many years, and he has a clinical trial, if you go on the website, using microbubbles to treat glioblastoma of the brain. So let's take a step back. Why are we doing this? Why are we using bubbles? Well, when we want to deliver products to the body, such as gene therapy, which is coming now, and there's 3 products approved by the FDA for gene therapy. Generally, the way you deliver a gene or a chemotherapy to a body is through an IV, but what carries it to the organ? Generally nothing. So how does a gene get in there? A gene doesn't. It needs to be escorted. So people generally use what they call viral-mediated therapy or adeno-associated viruses, AAVs. So they carry you right to the organ. What else can do that? We can. Our microbubbles can carry a load of genes or drugs, can circulate freely. But then we put the ultrasound beam, like Tom does, over the heart and disrupt them, so we release our products there, or we put them over the pancreas and we release our products in the pancreas or the brain. So guys, the microbubbles are a fantastic diagnostic tool, but they are also a therapeutic agent for the future, where you put something on the bubble, tell us where you want to go, put your probe there, disrupt them, and we treat it. Okay. And we have over 20 years of safe use of microbubbles. All right. So how many studies now are being done on gene therapy? Lots of gene therapies. There's over 700. This is old now. There's over 700 gene therapies stacked up. And are they using what as their delivery vehicle? Most of them viruses. So we are an alternative to a virus. Let me show you. This is a picture how simple it is. You have your microbubble here on the left. You put your load on it. You then do an ultrasound beam, and you can see what the ultrasound beam does. There's a full picture, and it disrupts them. We don't say destroy, we say disrupt. Generally, the genes and drugs are near or on the surface, so we don't really care if they're disrupted. Why? Because let's show you what is the concept that we're actually doing. This is the most remarkable picture on a small scale that I've ever seen. This is by Alfred Yu, University of Waterloo, Canada. All right, what are we doing here? That's a single cell on a petri dish. And the white little dot is a bubble. It's 2 microns. The cell is about 140 microns. You see that? What happened? Single cell, 1 bubble on top, ultrasound beam said disrupt. What did it do? It created a pore in the cell. And what does the pore do? It opens, and anything in the nearby area can go into the cell, such as genes, chemo, whatever you want. And then it seals. That is real time, by the way. So when you pop it now with the ultrasound beam, what you see is actually recorded. It's about 1 minute, so you've got a little bit of time to get in there. And the cell seals itself. So it is a remarkable tool. Nothing in the world acts like this. All right. That's the basis. So what is going on inside the little capillaries? You see this? When the ultrasound beam squeezes a bubble and then relaxes, compression and rarefaction, the walls in your capillaries don't like that. It's like you're pushing up against, now you're pulling back, pushing up. And what happens, you can see here that the cells lining the wall don't like that, and they begin to open spaces. Well, by doing that, you can get your material in. So you needn't always do what we call cavitation or disruption. You can do stable vibration. That is, vibrate like this. You know, it's like someone putting against your arm. You finally let them in the door, or you can just pop them once and break the whole wall. So there's two really different concepts on what we're talking about. And this is what we call inertial cavitation versus stable. Now I have to say, when you're doing your imaging on every day, you're using very low energy with microbubbles. So you are using what we call stable vibrational cavitation. You are not popping bubbles. Are you opening some pores in the heart that allow things to go in? Maybe. But generally, it has to be for a sustained period of time. Generally, we're doing it pretty quickly, and it's not really that. But when we're looking at tumors, that down here, these are the mechanisms. So it's a fascinating tool. And will we be called on to do this imaging in the future? Yes, because we are the imagers. What are some of the mechanisms? Lots of different things. There's a bubble sitting on a cell. The cell is the big triangle. And you see, when the bubbles push and pull, they create membrane disruptions. It's like scratching your skin. You're going to break through at some point. Fascinating work. Much of this work has been done by many people. Linda Jufermans wrote her PhD on this. There's probably 6 different mechanisms. Now, if you look up here, here's the bubble, here's the ultrasound beam, and you see all the different pathways into this cell. Fascinating work, but best shown by Alfred Yu when I showed you that video. That's really what's going on. All right, just a couple other fun facts. One therapy would be HDL. We treat LDL around the world with statins and PCSK9, and that have saved lives. It saves about 35% of the heart attacks by using statins, so 65% don't. Is HDL the good stuff? Well, if it's the right HDL, it's the good stuff. But here's a problem. When you have a heart attack, your good cholesterol drops 30% and will stay down for a month. Not only does it drop, its functionality drops. So when somebody has a heart attack, the good cholesterol drops and its function drops. So in the next 30 days, you have a problem. So we published a paper in 2015 saying, hey, we can use bubbles plus an ApoA1, which is the precursor of good cholesterol, and deliver it to rats and show that we can boost up their HDL. We did so. But before I jump right to that, you see what it's going to take. Here's the ultrasound probe up here. The bubbles are in the chamber. You open up the pore. The gene goes into the cell to the DNA. It's then transcribed by messenger RNA. It makes its protein out in the cytoplasm, and it spits it out to the serum. So these are the steps it takes. Within 2 hours of putting a bubble with a gene, we can see a protein secreted in the blood. That's not its peak. That's when it first starts. But the other thing is, folks, when you put a gene in a cell, it's constant. And so when you take a pill, you absorb it, it goes out, absorb it, goes out. No, when you put a gene in a cell, it will produce that protein forever, if it can. If it attaches to the chromosome, it will be there forever, but ours don't. Ours live out by themselves, and they will produce that protein on their own constantly. So it's a very nice therapy in the future. Let me just show you an example of what I'm saying. So we moved from rats to rabbits because their cholesterol is very similar to our cholesterol. And so what did we do? We put the beam over the liver, gave the bubbles, and we shot the ApoA1 gene into the liver. But one thing we noticed, in 3 days, here's the HDL level. At 100%, it dropped to roughly 50% in 3 days, just like a human, because they didn't like us putting them under anesthesia. They didn't like us touching them. And to them, it was a stress, like a heart attack. So their HDL basically goes into the toilet. It's not only low, but it's dysfunctional. And what did our group do? The group we treated went quite high. Because in that cell, that gene is producing HDL no matter what. It's not looking at stress. So it's a fascinating tool we now have. So you say, can we do this repeatedly? That's the nice thing, yes. Here was one injection. See the HDL bump up. Here's the next 10 days, and here's 20 days. So every time we re-injected the bubbles and the gene to raise the HDL, we were able to. And you can see the controls are red. They're always terrible. They're about 80% the normal because they're under stress. Okay. So when we wrote this years ago, this was in 2004, I think, we said that we would be able to do diagnostics and therapeutics. I think we will, and I think our echo labs will become an infusion center. in the future for other products. They will call on us probably in the chemotherapy wards. We are the experts at ultrasound and bubbles. And if we want to extend patients' lives using chemo or gene therapy, we're going to be called on, I believe. Thank you very much. We'll take questions and then a break. How's that? Thanks.
Any questions?
Yes, Val.
You're lowering down the settings.
Okay, good. The question is, when we do the therapy, what are the settings? That's a really tough question, Val. If we want to do stable vibrational cavitation like they did in Bergen to get the chemo in, they use low energy. Tom will use high energy for disruption. Some people like me use a combo. Val, there's going to be many questions on different organs. The brain may need different things, the kidney different things, the heart different things. Every organ has a different blood supply. So we will have to gear our acoustics to that organ. I can't answer that. I will tell you, we've done kidney studies. Man, if you knock the bubbles out in the kidney, in 2 seconds they come right back. It is so dynamic. In the liver, it's so slow. I mean, the big pools, you knock the bubbles out, you can wait 10 seconds before it fills back up with 20. And so the time that you disrupt the bubbles, it's going to be quite different. But everyone's going to take a little piece and figure it out. The really great question. The big question is, do you want to do low energy always, high energy, or hybrids? And I think that will depend on future research. Excellent point. Yes, ma'am.
So the comment earlier about the FDA wanting to go back to proving these bubbles as a device, is this the reason?
Tom's going to talk about this.
Okay, because of and then that's kind of backwards, right? Our diagnostic stuff is approved as a drug, that the therapeutic would be approved device?
Their comment to me, when I just put it for an investigation.
Oh, Tom, can you turn on? Thanks.
Their comment to me was that if you're going to use the ultrasound and microbubbles as a combination, then because ultrasound is a device, that then they wanted it to be used as a device. So obviously, just as you said, for diagnostic imaging, we're using ultrasound and microbubbles together, but they have this opinion that if it's going to be used for a therapeutic application, then that has to be changed, even though you're using the same diagnostic. And that we'll talk about. This is what's so exciting about this work is that we're using the same diagnostic ultrasound system that we're using for imaging, for perfusion imaging, for LVO applications, the FDA-approved applications of LVO. We're using that same technique. So, this is why we've looked at things like, are we altering the ejection fraction with the high MI impulses themselves when we do that in the lab? And we have seen ejection fractions get slightly better after we apply these high MI impulses in the echo lab. So when you do your ejection fraction measurement, it's very important probably to always take that into account, that you may be affecting it by a few percentage points by the high mechanical index impulse. So I understand why they're going to it as a device. It's just that why didn't they just always leave it that way?
Well, I will tell you that one. There was a suit by Stephen Quay.
So it was legal, not necessarily logical.
That's right. And Stephen Quay put a suit up. Tom, are you going for an IND?
For an IDE, investigational device exemption.
It's not a device. It's classified as a drug.
Why are you talking
I know.
I'm not the FDA. Okay.
But this is so interesting because they want to treat the bubbles as a device and the ultrasound as a device.
Because of that combination, even though.
Right, but one is a drug, classified as it.
Right. Well,
Okay.
It was originally, as you pointed out, it was originally a device.
And it should be.
And that's what it would have been nice just to
Tom,
leave it that way, but for legal reasons.
Listen, if you can look at the perfluorine gas, that is a device. Ophthalmologists all over the world use
Sure,
it.
yes.
And that is, you inject it right into the eyeball. It's not a drug. And that's what is the basis of our bubbles. Yet it's called a device and regulated as such. I looked that up and I called ophthalmologists. Oh, yeah, we have it over here. It's not a drug. We'll follow that with interest, Tom, because as we move into therapy and we're all going to be participating, are these bubbles then going to be just a device that we use?
Right, I think that's what they'll be regarded as, yes, for all the applications.
But chemo is a drug, and genes will be drugs. Okay, thanks. All right, any more comments? Great, thank you all very much. Perfect timing. Let's have a nice break, and then I think we come back, and it's Joey and Jessa. And then it'll be very soon, it'll be the Tom Porter Show.